Because I
Yep, we
want
got a
to test
thumbs
and be
up from
able to
everyone.
see. We're on? Okay. So, because I'm going to try to keep this interactive, not just with the people here, but with the people on Zoom as well. So let's see if we can channel their audio in and hear Vahid and Paul. And I've got Victor in the other room checking with them. Okay. So,
Hello, everyone. Can everybody hear me?
Victor, we can hear you in the other room, but we can't hear you here on the overheads in the room.
Hi, Mina. Hi, Basim. Hi, everybody. This is
There we go.
Wahid.
Vahid, awesome, awesome. So Vahid, I'll stop periodically, and I don't know if Serena is going to be able to join us as well, um, but I'll stop periodically. So for you and Paul, and if Serena joins us at any point in time, feel free to interrupt me, even if I don't pause. So we had a great talk from Bessem earlier this morning about the scapular anatomy and the functional anatomy of the scapula. And one of the things that we appreciated by listening to him is that sometimes we learn about the anatomy from the pathoanatomy, right? We see how things are supposed to be when we see how they go wrong. And there's going to be a little bit of this and a little bit of that in this talk as well. And I think when we are looking at rotator cuff tears, I want us to be able to step back and say, okay, well, what we learn about rotator cuff tears is telling us what the rotator cuff is doing when it's not torn. Does that make sense? Okay. So this is an overview. It's going to be 4 sections: neutral scapular position, if there is such a thing, normal rotator cuff function, small rotator cuff tears, and large rotator cuff tears. I don't think there's any way to do all of this stuff in an hour, right? And this is something that, we study over the course of years, and we kind of come back and we go and we learn, on a biomechanical level. We look at biomechanical studies, we look at clinical studies, we see what works in the operating room, we see, things that we notice in clinic, and we, create more questions. So this is an ongoing thing. So we could probably do this talk like every week for like the next 3 years and still be like, oh yeah, we never talked about that awesome paper out of this place. So I'll do my best to keep it as focused as possible so we're not all over the place. So the first half of the talk will be these 2 sections. And neutral scapular position, I think, is something that you guys know better than me as being like this, false thing, right? The scapula is a dynamic part of the scapulohumeral rhythm, right? So in certain positions, it's supposed to be, so in certain arm positions, it's supposed to be in a certain position, and in different arm positions, it's going to be in a different position. And we got a great appreciation for that in the lab, especially, and you guys saw my face, and I was like, whoa, okay, that's really awesome, like the different muscles in different positions. And when Bessem says, the scapula is the house of the rotator cuff, right? And he talks to us about the house of the rotator cuff and how it's on the back. I think what we're going to try to do here is to look inside the house. Right? We're going to go in, we're going to open the door, we're going to look around, we're going to check the furniture, we're going to see, okay, like, what does this table do? What is, is the shower working? Like, what's the flow like? So we're going to look at the more micro level, and it's important to recognize that, okay, if the house, right, is, tilted, right, everything in the house is going to shift, right? Like this nice couch, right? It's going to be rolling against the wall if the house is on an unstable foundation. So the spinal alignment, if the patient has kyphosis, scoliosis, if they just have normal spine but poor posture, right? All of that is going to affect their rotator cuff. When they're using their arm, right? The scapular position, like it's supposed to be here, and then when they raise their arm, it's supposed to tilt upwards. Does it do that? Are all the muscle balances that we talked about in the earlier part of the lab, and their awareness of where their shoulder blade is in space is going to affect their mechanics and their ability to use their arms, and all of that's going to have an indirect effect on the rotator cuff. Finally, the motion relationship to the humeral head, with the glenoid being positioned in space, it's going to orient the humeral head, and it's going to orient the rotator cuff. So all of these things are, before we even get into the nitty-gritty, before we get into the rotator cuff anatomy, we need to recognize that all of these things, the position of the acromion, the position of the glenoid, the position of the scapula, are going to be things that are, to a certain extent, beyond the scope of this talk that I'm giving, and things that we're isolating out, right? If we're talking about rotator cuff specific biomechanics, we're going to assume that everything upstream from that is going to be normal, right? So all the stuff that we talked about with Bessem this morning, we're going to say, okay, let's assume all of that is normal. Let's zoom in on the rotator cuff and see how the rotator cuff is functioning. So from an anatomic standpoint, I think it seems like, okay, like supraspinatus, subscapularis, infraspinatus, teres minor. Like, what could be so hard about that? But it's underestimated, I think, how misleading the anatomy can be, and where each of these tendons attach, where these muscles attach, and what functions they have is something that is not as straightforward as it seems. So in 2008, which, seems like, I guess, a long time ago, but for those of us that were training around that time, it was like a completely mind-blowing article that came out in JBJS, and my understanding, I don't know if Serena, are you there?
I'm here.
Awesome. So I think you share my love for this article as well.
I do. Yeah, the Mochizuki article. Yeah, I love it.
So what's the angle that you take on this that you think is so critical? And I'll put this picture up, because this is my favorite picture from the article. Maybe it's the same for you, but maybe it's different. Like, what was your take on this article that made it such a game changer?
Yeah, I mean, I think it totally changed how we think about the supraspinatus in general. And so, I take this article in connection with an article that Ken Yamaguchi and Jay Keener published years ago about where cuff tears initiate. And it means a lot to me, because people used to think the supraspinatus was this, larger tendon that encompassed a huge footprint. And this article showed us that the supraspinatus is actually very small. It's only about 1 to 2 millimeters on its lateral side and 12 millimeters or so on its medial insertion. And so if you look at this paper, if you look at how we used to think about things, we'd think that all tears initiated at the leading edge of the supraspinatus, or at least most tears, even if they involve the rotator crescent, which I'm sure you'll talk about, will, involve the supraspinatus. But now this article actually kind of crystallizes that most of the tears that we see, which are in that 15 millimeters posterior to the biceps region, is right at that junction, that medial junction of where on that picture you have there, the pink meets the blue. It's right in that rotator crescent where it's the most stress shielded and lowest vascularity area. So for me, this is like my favorite article to pimp residents and fellows on, because even still, I think a lot of people just don't appreciate that the supraspinatus is not this big muscle. And it leads further credence to the fact that people function really well with a torn supraspinatus, that it's, the most commonly torn one that doesn't really lead to functional consequences as long as the anterior portion is intact. So, I love this article. I'm interested to hear why you love it.
So I was doing my research year around the same time as this article came out. So my research year was 2009, so it was like the year right after. And, the orthopedic dogma prior to that was exactly this, like Serena was saying, like this, large supraspinatus attachment that you see in the left picture. And what they demonstrated was that the infraspinatus actually wraps around. So there's this layer of tissue. And when you take away that layer of tissue that is covering the confluence between the supraspinatus and the infraspinatus, and you remove that, so in this left picture, it's what you'd normally see, and what you want to think is, okay, like the supraspinatus, is attaching right where that star is, and that's the center of the supraspinatus. But if you peel away that superficial layer of tissue, you see that the infraspinatus actually wraps around, and you see those arrows, right? And I remember doing these dissections, like in the lab, like, trying to figure out the biomechanical study that we were going to do and how we're going to study it. And it was mind-blowing. It was like, wait, this is all infraspinatus? And I'll show you guys some arthroscopy pictures later from, a case of mine. And you can see it. Like, it's a very common thing to see the infraspinatus wrapping around like that. And it's a real thing that we see at the time of surgery. So I think if we take it for granted that we think we know where the supraspinatus attaches, then we're not, like we were talking about earlier, like the eye is not ready to see what the mind is not ready to comprehend. So if we think like, oh, we know where it is, then we don't question it. But these guys were able to question that and teach us something that we didn't see before. So the key points are the infraspinatus is larger than previously thought. And another point in the article that was surprising is that 20%, it was actually 21% of the time, they had like 113 cadaveric specimens, and 21% of those specimens, part of the supraspinatus actually attached to the lesser tuberosity. So that is the anterior cable attachment. And if you...
Can I ask a question?
Yeah, of course.
Sorena, how are you?
Go easy.
Is he still here?
Yeah, Serena's here, yeah.
Sorena, this
Oh, actually, hold on a second. Let me give you this, so that because he might not be able to hear you if you're not on the.
Okay. Hey, Sorena, how are you? This is Basim here. How are you doing?
Hey, Basim, how are you? Sorry, I
Fine.
can't be there with you.
Good, good. It's like Joey. How you doing? Okay. So let me ask you then this question. This is very sexy study. I agree. And so tell me this. So right now, even though this is along the same topic, but not exactly, if you see the failure of SCR in patients who have irreparable posterior superior rotator cuff tear, there are a lot of failure related to glenoid or a humeral attachment, whatever, but most of them, because if they lack external rotation and they have no infra, they don't do very well. So my question for you, and based on this, if we do prospective randomized study and we'll be able to repair an infraspinatus, and you do two group, one you do an SCR, one you don't do SCR, what do you think is going to be the difference between the two groups based on this anatomic study?
I think if you're able to repair the infraspinatus, adding the SCR to your repair probably would not lead to any difference. And the reason I say that, and I say that the U.S. style SCR, not the Mesiha SCR, because I think that's a different animal. But the U.S. SCR, if you look at the results of doing SCR and you compare it to partial repair in our own literature, the results are the same. And so I don't know that mechanically you get a lot more in terms of balancing the shoulder if you have an SCR added to a situation where you already have an intact healed infraspinatus.
Great.
What do you
Yes.
think?
No, I'm with you 100%, and this is why, because based on this, if you because I know you like to do a lot of studies, and I like your studies, even though I like to argue with you just to make you smile and stuff because you're crazy, but it's but in this case, if you honestly, and you have like a group of therapists here, and even for surgeon in general, we learned what's the function of the supraspinatus biomechanically in the past and what does it do early on in the motion. And I'm not sure you have another study coming up, but based on this anatomic study, what do you think the main function of the supraspinatus in the context of the whole rotator cuff?
Honestly, I think you know the answer to that better than I do. I'm not totally sure. I think it probably helps just initiate elevation. Beyond that, I'm not certain. What do you think?
Yeah, again, we cannot argue today because we're on the same line. So I totally agree with you, and I know you do a lot of lower trap, and I know lower trap is not rotator cuff. By the way, there's nothing like a lower trap, the rotator cuff. So we're trying to come up with the tendon transfers options just to try to optimize rotator cuff tear, but there's nothing like the rotator cuff. This is why they put them this way, because they're amazing. They're small muscle, but they're very powerful. But we try as much as possible to replicate them. But this is why a lot of patients, as long as they don't have even with those with pseudoparalysis, but as long as they don't have a very advanced arthritis or really severe pseudoparalysis, usually be able to balance them enough with the trapezius transfer. And I get this question very often. They say, like, but the trapezius does not depress the head, the latissimus does. And I think the concept is wrong. The trapezius try to restore the force couple. This is it. And the deltoid has to do the elevation. Trapezius does not do elevation. Trapezius, we're trying along the same line as the infraspinatus to try to restore the force couple for the deltoid to function. And this works along the same line as the study. And I really like the study a lot because I totally agree about the insertion site of the supra, even though it will be interesting if you can correlate this study with the anatomy of the supra insertion with the MRI reading when we talk about supraspinatus tear, the width of the tear, the thickness of the tear, because many times you see like it is almost on MRI, it looks broader than what looks like here on this anatomic study. And I wonder whether this part of it, because there's some infra, but it's read as supra.
So let me translate a little bit. So I love when Bassem like takes something so complex and he makes it simple, and something so simple, and then we go off on this like journey where I was like, wait, hold on. We're trying to like walk people through like one step at a time. And we just went from the rotator cuff insertion to reconstructing with an SCR. So an SCR is a superior capsular reconstruction. It's something that has been described within probably like the last 10 years, I think. And it's, I don't think it's unfair to say it's a little controversial. I think there's a lot of people that are big proponents of it and think that it's a great operation for people that have a superior cuff deficiency. And there's some people that are more skeptical. I think the question that Bassem is getting at is if we know what the supraspinatus does, then when it's not there, we know what we need to do to compensate for it, right? Like that's the fundamental question, right? If we don't know what it does, then if it's not there, we don't know how to replace it, right? Like if we have a chair and, you know, we don't have the chair anymore, you don't replace it with a palm tree and say, you see, we're problem solved. It's like, no, that doesn't do anything, right? So one thing that I'm focusing on today, and like I said, like there's no way to encompass all of this literature in just an hour, is the microfunction, and when it's working normally, or when you have a small tear, what you're trying to restore. And I think that's a different question than if it becomes irreparable, or if the function is completely absent and is not restorable with a normal cuff anatomy. I think let's put a pin in that. Like, let's make that a talk for a different day.
No, this is, by the way, like this will be, in fact, a good introduction to your talk. Yeah. First of all, because we have Serena that will be able to ask him a question. And second, we spoke about something, even though it's not the scope of this one, to see right now from your talk, what will it be to do if you want to repair a small tear of the supraspinatus.
Right. And it's so hard because if you're starting to get into this, you know, irreparable, like salvage question, you really have to get a good sense of the effect that these tears have on glenohumeral kinematics and translation. And there's some literature out there, but I think that it's really tough to put that all together. I actually found an article that was in German, and I was like bouncing back and forth from like the article to like Google Translate to be like what are these guys saying? And they were talking about the force vectors of the supraspinatus and the infraspinatus and the combination vectors, and you were talking about the force couple, right? So very, very simple, and I say this to my patients in clinic sometimes, is if you have a rein on a horse, right? If you pull to the right, the horse goes to the right. If you pull on the left, the horse goes to the left. If you pull back on the same, the horse goes back. So if the infraspinatus and the subscapularis, right? The infraspinatus is an external rotation, the subscapularis is a internal rotator, if they both pull back together, it's compression and inferior depression, right? So if your superior cuff is deficient, but your anterior and posterior force couple is intact, those two muscles working together can help to give a fulcrum for the deltoid against which to lift. That's why you can have some people, as long as they have good internal and external rotation, and that's why it's at least reasonable to me for people to do internal and external rotation strengthening exercise in addition to doing their scaption exercises, right? So the anterior and posterior. I'm sorry, what was that?
Not me this time.
Sarah?
That's Vahid speaking Farsi to his family without being
Oh.
on mute.
I'm like, are these structures I haven't heard of before? I'm like, I've never heard of that. Okay, so good. I'm not behind on anatomic structures that have been described. Okay, good. So yeah, so I think these macro movements and these macro kinematics are interesting in and of themselves. But again, today let's just focus on the local microanatomy. And here, this is an article by Burkhart and Esch in 1993 that described this rotator cable. And the rotator cable attaches anteriorly, right? And you can see here, even Burkhart describes that some of this, and you can call it the leading edge of the supraspinatus, or you can call it the anterior cable attachment. I'm agnostic, and I think in Serena's article that I'm going to reference later, I think they preferred the terminology anterior supraspinatus. In our article, which is a biomechanical article, we called it the anterior cable attachment. I like I said, I'm agnostic to which one you call it, but that anterior thick load-bearing structure is really important, and then the posterior part of that structure, and we'll get to see this in the lab. This is not like a made-up thing, right? You're going to see it, and you're going to feel it in your fingers in the lab and say, oh, okay, so this is a real thing. So when the supraspinatus pulls, right, so it pulls down in the direction of that muscle belly, it's not pulling uniformly across the greater tuberosity. Right? It's going to pull preferentially through the cable to that anterior cable attachment and posteriorly to the posterior cable attachment. And that's why they call it a suspension bridge. Right? So this suspension bridge really distributes forces in a way that is not as straightforward as you think, right? Like the roadway, you're driving across the roadway and you think, okay, like it's all just uniform across the roadway, but that's not true. All of the force is being distributed to those pillars, and the pillars down to the ground, where the pillars are, fixed at the base of the bridge. So when you're looking at the rotator cuff, it's the anterior cable insertion, that's the anterior pillar, and the posterior cable insertion, that's the posterior pillar. And the area that's between them doesn't really matter, right? If you look at a bridge, you don't have cables, you don't have pillars, you don't have anything in that stress-shielded area. So in orthopedics, whether it's bone or tendon, the more you load something, right, the more it becomes reinforced and the stronger that it gets. The less you load something, the more relatively stress shielded it becomes, and the more it sort of withers. And the papers that Serena was referencing earlier were out of St. Louis, where Serena did his fellowship. Like, phenomenal program over there. With at the time it was Jay Keener and Lisa Galitz and Ken Yamaguchi, like these powerhouses of shoulder surgery. And they described that it's not really what we thought before, that most rotator cuff tears start at the anterior supraspinatus where the anterior cable insertion is. We thought that because that's what we saw, right? So if most patients come in, right, and they are symptomatic because they have tears of the anterior cable insertion, then it's easy to think, oh, well, that's where most of the tears start. No, those are the people that are showing up to the clinic. If you do tests on asymptomatic patients and you're doing these ultrasound exams on them and you're seeing where these tears actually start, and I'm regretting that I didn't include this paper because they have a beautiful, beautiful histogram, like schematic, of where these tears start. And like Serena was saying, they start 10 to 15 millimeters behind the biceps groove. So it's not the anterior supraspinatus where these tears start. It's in this stress-shielded region, right? Because that area, poor vascular supply, not seeing a lot of stress, it kind of degenerates over time, but people don't even know that, right? They show up in the clinic when they start to have symptoms. When do they start to have symptoms? When it starts involving the anterior cable. Does that make sense? Because I think that's a really, really critical point that he was making earlier. Serena, is that what you were getting? Like, is there anything else you wanted to add on that?
No, I think you're summarizing this like perfectly. You know, the one comment that I'd make that I think is kind of interesting is I think the cable is adaptive. You know, there was a study that was published 2 years ago by Dan Davis and Matt Ramsey, where they looked at the arthroscopy videos of patients, and based on age, the cable was way more prevalent past age 40, and you really didn't see it below age 40. So it seems like it's something that forms over time as the rotator cuff sees stress and probably changes or adapts. So it's interesting because I don't think that the cable is something that we're born with. It's something that forms over time.
That's wild. I mean, it makes sense. Like I just said, like it's something that will hypertrophy over time, or if it's stress shielded. So it makes sense, but I never even considered the longitudinal like time base. So that's really interesting.
Mina,
Yeah, Vahid,
just like a quick comment,
please.
I wanted to.
Can you do it in Persian, please? I'm just-
Hi, Serena. Hi, Bassem.
Yeah.
So when
Hey,
you
Bo.
look at Burkhardt's first data, he actually, although there's not a lot of data in that paper, it's surprisingly, when you read it, it's just a lot of pictures and kind of hypothesis. But one thing they actually showed that in their cadavers was the same older patients, and they speculated that as Serena said, as the crescent gets thinner and thinner, that adaptive changes or differentiation between the crescent and the cable becomes more apparent as the patients age.
Thank you, Vahid.
Sure.
So again, recap. Yes, Jen.
So do you think that the cable is getting thicker as we age, or do you think the rest of the tissue is thinning and making it more visual?
So, Serena, I don't know if you can hear Jen's question, but she was asking, do we think that the cable is getting thicker, or do we think that it's just relative thickening in comparison to the crescent thinning? Does Ramsey's study have a comment on that?
That's a great question. We don't know because, arthroscopically, you can't really measure the thickness very well. So, I think that would have to be an anatomic study that you do over time. But that's a great question. I don't know the answer to that. I don't know if it's the crescent getting thinner and the cable just looks thicker, or if the cable is actually hypertrophying. I have no idea.
And the numbers that you'd need to really, because there's such a variability from one person to the next, like in terms of size. And in addition to the standardization with respect to sex and size, there's going to be a standardization with respect to age, right? So to get enough time points, so, a 20-year-old specimen, a 25-year-old specimen, a 40-year-old, to be able to make these comparisons, you'd need a lot of cadavers. So it's a great question. So we've covered the first half with the scapular position and the normal rotator cuff function. So now let's look at the pathology and what that pathology teaches us. So I've got Serena's study here as the clinical study, and our study that was a remarkably interdisciplinary study in Cleveland. So Kathy Derwin was the PhD. Jesse McCarron was my surgeon mentor. The other two guys are finite element modeling engineers that helped us to do the data analysis and to be able to track. So these were awesome people that helped us to be able to look at the rotator cuff anatomy. And it was a very, very simple question. All these questions about like what does the supraspinatus do, and what happens when it's not there, and how do we account for that? Those are all really like important questions. But the real question that we were focusing on was the biomechanical analog of the Keener paper, the one out of St. Louis that was talking about where these tears initiate, right? So what they found clinically was the tears likely initiate in the 10 to 15 millimeters behind the bicipital groove. And the ones that are more symptomatic are the ones that involve the anterior cable. So we said, okay, so let's study that. And the biomechanical setup was looking at the supraspinatus and cycling the supraspinatus and the changes that happen in the biomechanics of the supraspinatus as it relates to the gapping, so how far the tendon was going away from the bone, and this is where the finite element modeling came in, the changes over the course of the tendon in terms of its strain patterns. And what we saw was if you create the tear in the crescent, right, so if you keep the cable intact, the way that the tendon was cycling and the way that it was pulling was pretty much normal, right? And one of the criticisms would be, well, that's not the supraspinatus attachment anyway, right? Because Mochizuki already told us that the supraspinatus attaches in the anterior rotator cuff. And I think a different study that could be done would be to do the same study but cycling the infraspinatus, right? So this study actually took 3 years to do. So I think to do the same study again may be easier than that first time around, but I think that's a study that's worth doing. But my guess is that even if you cycle the infraspinatus, you'll get the same result because those forces will be propagated around the tear, right, through the cable. And it's completely different when you make the same size tear, right? So if you take the if you take the crescent and you tear it, nothing happens. If you make the same size tear in the anterior attachment of the supraspinatus in the rotator cable region, the biomechanics of the shoulder completely change, right? There's a lot more gapping. There's a lot more disruption of the strain. And what that means we'll get to, but just purely looking at the tear location, not the tear size, had a profound difference in how it affected the loading of the supraspinatus. And this is corroborated by Serena's study. Serena, do you want to present it, or do you want me to make a couple quick points and then you can chime in?
Yeah, go ahead. Do your thing.
So I'm just going to make a couple quick points, and then Serena, you can fill in more about your hopes and dreams for this article and what you guys were able to show. But I think it was so interesting that they basically showed that clinically, and these two articles were like ships in the night, right? Like these articles are kind of going on in the background, like one in the research lab and one, looking at clinical patients. One came out in 2013, one came out in 2014, and obviously we didn't know about each other's studies, right? Like they're being published and worked on in the pipeline at the same time. And what you see is that they're showing the same thing. The patients who had tears that were adjacent to the bicipital groove are these tears on the right. You can see the distance to the biceps tendon in that group 2 on the right side is 0 to 1, right? So the tear extended into the bicipital groove and involved the anterior cable. And in group 1, the group that's to your left, these were the ones that were further back. And which ones were more likely to have atrophy? It was the ones that you'd expect based on the biomechanical data, right? The ones that had an intact anterior cable, the force from the muscle through the tendon to the bone was being kept intact, and that muscle kept working like it normally did. The ones with that anterior cable tear in group 2, the muscle was pulling on the tendon, not really being loaded, and as we know, use it or lose it, so the muscle ended up atrophying. So the take-home points from both of these papers, The rotator cable anterior supraspinatus, again, we're agnostic what we want to call it, is the primary load-bearing structure. That posterior part of the supraspinatus with the crescent is relatively stress shielded and less important. I'm going out a little bit on a limb with the third one, but I think the first two conclusions here are fairly straightforward. One, anterior supraspinatus tears are more likely to be symptomatic. They're more likely to progress to fatty atrophy from muscle disuse. I think the third one is a little bit controversial. I think the biomechanical argument is stronger than the clinical argument here because we haven't found the clinical data to support the statement, but I think it's true that strain in the rotator cuff in an anterior cable tear is higher, and therefore if the strain is higher and how that tendon is moving is abnormal, it's more likely to have these forces propagate and have the tear propagate and lead to tear extension. I don't think there's any clinical data that supports that, but looking at the biomechanics, and we'll go into the lab and I'll show you guys. I'm like, okay, like if you make a small tear here in the rotator crescent and you pull, everything looks normal. You take a different specimen, you make a small tear, same size, in the anterior cable, you look at that rotator cuff and the way that it's pulling and the way that it's loading against the bone is completely different. And I have to believe that is going to create an abnormal environment that's going to make it likely to tear, extend. So, Serena, do you have a comment on that specifically and then generally on your paper?
No, I mean, I think the paper is interesting clinically because it supports what you found, mechanically in the lab. The thing that we did not find was that fixing tears that involved the cable led to any different in result than fixing tears that didn't involve the cable. So it seems that both respond well to surgical treatment. It's just that you have to have a little bit more vigilance when you look at a tear that involves the cable, because that one may progress a little bit more rapidly to atrophy and potentially could become irreparable faster. So those are things that I do counsel patients on when I see them and I see that tear that is a very leading edge tear with some retraction. I'd like to ask Bassem a question, if you don't mind me getting just a hair into the weeds. And it's only because, when he's around, I feel like I have to ask a really smart person a really stupid question. So, my question is, now we talk about, and for the audience, we talk about tears when the cable is not there and is not fixable. There's this thought about doing an anterior cable reconstruction using the long head of the biceps tendon, which is right next to it, essentially cutting it, not from the supraglenoid tubercle, but further down and attaching it to the anterior insertion of the supraspinatus, right where that cable would be. And my question is whether Bassem thinks that there's any value in doing that.
Serena, this is a great question, by the way. So I don't think so, except if what you're talking about is trying to repair the supra, and you have some, you're not satisfied, and you still have some anterior defect, and you're trying to bridge it. You can, as you know right now, and I'm sorry I have to talk about this because this is a form of autogenous SCR. It is the people use it because instead of using a graft to put it inside the shoulder, they use a portion of the biceps as a portion, almost like a capsular reconstruction. And I'm not really a big fan of it, except if you want to augment the supra. Then in this case, based on your study and based on anatomic studies, I do feel there is some value to it, but not by itself. And most importantly, and you know that very well, I'm still skeptical about the origin insertion of the biceps at this location. What I mean is they flip the biceps from the labrum and you attach it on the humerus. And now when you move, even though by concept this looks like an anterior cable, it's not, because this one is attached to a labrum on the glenoid. So your motion, essentially, you can tear it, you can cause labral tear, and it is not the tension of it. So this is why I'm not really sure, Serena, about this one. Honestly, I'm really skeptical about it. I would say possibly as a tissue because it is autogenous, it is collagen. If you're adding to a supraspinatus, that's questionable. You want to add it to it, I think it may be of value, but I'm not really sure about the rest of the cases.
Yeah, I would echo that, and I think the biceps tendon is not going to be a dynamic structure like the cable is a dynamic structure. Like the function of the cable is not in and of itself. It's because it transmits the force from the supraspinatus to the anterior part of the greater tuberosity. If there's nothing pulling on that cable, it's no longer a cable. And that's what's happening with the biceps tendon. It's attached to the top of the glenoid. It's not pulling in that direction, so it's not going to serve the same function, unfortunately. Sarana, what do you think? Or Vahid?
Yeah, no, I mean, I love the way you just summarized that, actually. I mean, I think, we talk about it like it's a reconstruction in the same way that we think about, something providing the same function, but it's not attached to a muscle. And so I just find it hard to believe that it would have the same dynamic effect that a cable actually has in terms of restoring force couples. Bassem touched on it earlier. He said that when you restore the force couple using a lower trap transfer, you get a centering effect of the head, and he's absolutely right. The patients that I've had where I've restored the force couple, the head actually is lower on their post-op x-rays. But if you just try to add a thin piece of tissue on top of the shoulder just to prevent it from going up, I don't think that it works nearly the same way.
This is Vahid.
Is that Vahid? Okay. I think, Bassem, you, at the Academy meeting a couple weeks ago, you commented on that with a patient who had a deficient subscap that a surgeon did a lower trapezius transfer with the hopes of restoring this force couple, but a force couple requires the couple, right? Like having the external rotator without the internal rotator. And you had said if he had done a parachute technique, that would have been, so if you can elaborate on that.
So, I'm glad that we have also Serena and Vahid. Both of them are really smart. And sincerely, there is some concepts that we have, they're not correct. Yeah. What I mean is, when they used to do latissimus transfer for a long time. Yeah. And I'm not going to mention who. Some of the very, very good shoulder surgeons, they say yes, because the latissimus flex the shoulder up. That is absolutely ridiculous, because latissimus, when you transfer it, you can do it in the lab right now. I'll show you. Yeah. Put the latissimus on top of the humerus, suture it, and pull on it. See what's going to happen. Subluxate the shoulder down. It does not flex the shoulder. The whole concept of the tendon transfer is to restore the force couple. And if you can get a force couple as close as normal to what's supposed to be, this is what we're talking about, and Sorian talking about, then you're going to get the function that you want. Quickly, I know, again, not the scope of this one, but if you ask anyone, like if you ask Vahid, or you can ask like Sorena, if the deltoid is paralyzed, would you do tendon latissimus transfer to restore the shoulder? They will say, no, you cannot. If you ask Christian Gerber, who came up with the technique, he will tell you this is forbidden. Why? Because subluxate. So hear me out here. How do you do a tendon transfer that you cannot do exceptionally, except if the deltoid is perfect, is not an ideal transfer to restore the force couple. This is why trapezius early on for paralysis, you don't need a deltoid to restore the force couple. So the idea is always to try to restore the mechanics, which is the force couple. Now, if you have someone who has no front, no back, no muscle, you cannot put only one force couple in the back and you put tendon in the front, or you assume there are two muscles absent, and you take a piece of skin, you slash it on the shoulder, you say it's gonna be okay. So this is what we're talking about, essentially restoring the force couple for the deltoid to be able to function well.
Right. And I think, again, it's not necessarily what I was focusing on in the talk, but and it's something we can elaborate on in the future.
I'm sorry we get excited about this topic.
No, but I think it's relevant and it's helpful. And if we like, even though it's not going to be in the slide presentation, if we walk away with that concept of that force couple, with maybe, if you like, the horse reins analogy, the subscap and the infraspinatus, right? If the subscap is intact, the infraspinatus and the external rotators are gone, you restore that with the lower trapezius transfer, and then you've restored that force couple, right? If the external rotators is restored and the subscap is deficient, it's not a force couple. You can't control a horse with just one rein. It's just going to turn left every time, right? So in order to do that, what Bassem has described is you do the external rotators with the lower trapezius transfer and the internal rotators with the latissimus transfer in the front. So it's different than the latissimus transfer in the back that he was talking about. But that's what I really want to see in the lab as well, which is not the one that doesn't work, but the one that does work, which is where do we put the latissimus up the front so it restores the internal rotators. So that's the parachute technique where you connect the two. So moving on. So priorities for repair, you want to bring the posterior superior cuff back to the posterior cable attachment and bring the anterior superior cuff back to the anterior cable attachment. And I think functionally this is kind of what we end up with, because I will switch here to these scope pictures that I have. You guys can see that, right? Is that decently clear? So you can see here, this is and I had videos, but the videos aren't edited, and we'll just sit here kind of sloshing through them. Anybody that wants to see these, I'm happy to sit there and explain to you with the animation, but we'll just keep the status pictures for now just because it's going to help us from a time standpoint. So you can see here, the posterior cable attachment is disrupted, the anterior cable attachment is disrupted, and this is the dilator for the anchor that we're putting in the back, and then the anchor that we're putting in the back, and then the sutures getting passed through. And the way that these are being passed through is with a modified Mason-Allen. And a Mason-Allen is basically like a suture that locks into itself. And the way that we're doing this arthroscopically is these blue sutures are being passed up horizontally like this, and then we'll tie the blue ones together, and then the white one gets passed between them, right? So the blue are going to be closed like this, and then the white loops around the blue, and it's going to bring the tendon back to the bone, and the blue is going to keep it from cutting through the tissue. Does that make sense? It's kind of like a ripstop effect. So this is the anterior attachment here, and this is me grabbing the tendon and showing the patient that, once we pass these sutures, that tendon gets brought back to the bone. And again, here the two blues are passed like this, and the two whites, just the one is in and the other one is out. And this is us tying them, and you can see I'm tying the blue ones first. And once the blues are tied, the whites are tied over it like that, and that's bringing the tendon back to the bone. And again, this is the front. We're tying the blue ones first. And once they're all tied, you can see we've spot welded here the front cable attachment and here the back cable attachment. This area in between, stress shielded, not that big of a deal. And as long as there's enough tissue bridging between these two, this part doesn't need to be necessarily repaired back to the bone. You can leave that gap between them. And functionally, even if we wanted to, there's really not enough room in there to put a third anchor, right? So you're not going to put just one anchor in the middle and bring everything to that one anchor, because you're going to say, I'm a surgeon, I like to put more anchors, right? So you're going to put two anchors, right? And when you put two anchors, you're not going to put them all in the back or all in the front. So I think our clinical experience and what we're doing clinically in the operating room may or may not be determined by our biomechanical understanding of what the rotator cuff does, but I think this is pretty much what everyone does with a single row repair, and it just happens to lend itself really well to the biomechanics, and that's why these repairs work. It's this is another look at that same repair, and another one because I'm unfortunately falling in love with it and saying, look at that looks really good. So this is a similar tear that I felt to be more mobile and more restorable. And we'll have the other surgeons comment on whether they do this or whether they have sort of just a routine to only do single row or only do double row. these patients were, 1 week apart. One was last Friday, the other one was the previous Friday. I got permission from both of them. I'm very grateful to both of them for giving me permission to share their pictures. But one of them I felt would do better because it was an older patient, less mobile tissue. I did that single row repair. This was a younger patient with more mobile tissue, and I felt like if I put one anchor here in the back, I was able to pass the sutures instead of with this modified Mason Allen with the horizontal and the vertical. I passed them all horizontally like this, and you'll see it's alternating blue, white. And I did the same thing with the front. So this is the front anchor going in, and then it's blue, white in the front. And then I took all of the blues and put them in to a lateral row anchor. So instead of tying knots, we're bringing all of the sutures to this lateral row anchor, and that's the anchor there at the bottom. And this is the front lateral row anchor, and you can see this is a suspension bridge construct where you've got the two anchors here, all the blue sutures going to the back, all the white sutures going to the front, and cinching down the tendon. Either way, I think functionally speaking, the difference between them is not restoring the cable attachment. It's how much, like the difference between them is how much contact you get between the tendon and the bone. And I think this double row repair with the 4 anchors gives you more tendon to bone contact. So when it's possible, when it's a younger patient with a more mobile tendon, but I think in both cases, whether it's a single row repair or a double row repair, the primary goal for this operation is to restore those cable attachments. So I don't know if Serena, Vahid, Bassem, if you guys, Bassem, this is probably too easy for you. You haven't done one of these in 20 years. So maybe Serena or Vahid, the mortals on our panel, can comment.
Yeah, last time Bassem fixed a rotator cuff, it was attached to somebody who'd had 50 other operations and a flail arm.
Oh, Serena.
But no, I think the one of the things that you kind of are alluding to is that tension-free repair is probably more important than the actual technique that we use, and restoring the anatomy is way more important than the actual, construct of the sutures. So every tear is a little bit unique and a little bit different, and we nerd out about them. But fixing every tear the exact same way is probably a mistake.
And do you think that people are doing it on purpose where they're, so I guess there's a assumed premise there that we should be repairing the posterior and anterior cable attachments. Do you agree with me that those are priorities for repair? And if so, do you think people are doing that deliberately or just as a function of the sort of technique that it happens to lend itself to that?
I think that most of the time people have a set way that they fix their rotator cuffs, and they do that for every case. And so fortunately, most of the time they probably by default repair the cables, but I think a lot of times some of the techniques call for a little bit too much tension on the tissue in order to get the type of construct or repair that you're aiming to get. So, that may be an issue for healing. But I think if you repair it more anatomically, the way that you've shown, you probably have less tension on your tissue and a higher chance that your repair will actually heal.
And I'm showing this view here, and I think it's really important to look laterally, because sometimes instead of having that infraspinatus, as we saw from the Mochizuki article, and this is what we're talking about here. So you guys see the infraspinatus, it's coming around here and wrapping around nicely, right? Sometimes if you look underneath and you lift up this edge of tissue, you see a delaminated infraspinatus tear underneath that I think needs to be fixed as well. And I think if somebody misses that and they just repair this chip shot supraspinatus and they don't spend the extra time, effort looking, finding, and fixing that delaminated infraspinatus tear underneath, I think that is a common source of failure. Do you guys tend to see that sometimes in revisions that you're getting secondhand?
Yeah, I agree. That delamination is very important, but I will make a comment. Your cuffs seem that, they were tear a few hours before before you were fixing them. There's actually blood supply. They're not Ohio, like, BMI of, you know, those are the,
Fluffy classification, please.
I'm fluffy five. And, but joking aside, I mean, the importance of this, these articles, I think, I've learned from Serena is to recognizing also the pattern in your cuff tears. I mean, your smaller tears tend to stay where they anatomically belong, but as the tear gets bigger, and you as a surgeon, a big part of your job when you're repairing is to know what goes where, and kind of knowing this native anatomy helps you that when you have a reverse L shape and appears like a crescent, not making a mistake of bringing all that tissue lateral and creating a high tension repair, and knowing that a big part of that and how that tendon is mobile in what direction gives you clues about what structure was torn. And the interesting part of that paper, the favorite paper that we all kind of learned a lot about, was that it showed 20% of cadavers actually had attachments of supra and lesser tuberosity. So these goes to tell you that like this whole structure creates a cuff, and that's one of the things that when I'm done with a cuff repair, when I'm moving the arm in the operating room, I always that's my last check. Did I create a cuff that's going to extend from the front all the way to back, or is there big holes? And that's to me is the most important kind of technically final check to say I'm containing the head and I'm creating the cuff that extends from the front all the way back. I don't know how you guys find that important, but I think pattern recognition, as Serena said, not creating tension across, doing partial repairs whenever you think that you cannot restore anatomy, and also like a lot of times I feel like when they talk about infra to SCR repairs, like it just like creates a cuff of continuous tissue. And yes, like if you talk to Boston, you shouldn't be doing SCR at all. But point being, you're essentially creating a continuous tissue over the humeral head.
Yeah, I was diplomatic about it earlier, and I was like, well, some people still have some outstanding questions and concerns regarding the efficacy of the superior capsule reconstruction. I'm actually one of those people, for what that's worth. And I wouldn't feel too bad for yourself, Vahid, because I was getting made fun of actually in the OR. They were like, "Oh, no rodeo tears today," because the rarity of getting two patients in a row with these small cuffs is was
They
like
exist.
Yeah, I mean they are out there. They just don't find me for some reason. So they just happened to come in the 2 weeks right before this gathering here. So we got lucky with that, because I think the supra, infra, subscap, 10 anchor repairs that are normally coming into my clinic are less educational than this, I think. So anyway, back to so we got our normal anatomy, we got our small tears, the priorities for repair, what you're trying to reconstruct. For large rotator cuff tears, I think we need to say something about them. I think if we're going to talk about the biomechanical studies and we're going to look at it in the lab, there are so many factors like scapular position, how much deltoid force, the degree of the force couple. I think there was an article that was looking at massive tears, that was looking at 6, 7, and 8 centimeter tears, and looking at the force vectors that are related to that. I think it's really, really hard when you get into that level of complexity to really be able to isolate a clinical question biomechanically in the lab, to be able to say, okay, I'm going to take this information and generalize it. In this realm, everybody's like a snowflake. everybody is completely unique and completely different. Like people's demands, how they got there, the chronicity of their injury, how much pain they're having, what their expectations are, what their demands are. So I think the biomechanical studies here, for me at least, tend to be less beneficial, and understanding at a microbiomechanical level is going to be less helpful than just stepping back and looking at their physical exam. So when people have these large, massive rotator cuff tears, the active forward elevation is likely going to be less than their passive forward elevation. So, you'll be able to get them to lift here, and then they're able to lift higher with assistance. To me, I think it's helpful to know if they're able to maintain that on their own. You can call that whatever you like. I think most commonly it's called the drop arm test. I think it's a little misleading because I don't let people drop their arms. Like, I'm not going to help them to get up there and be like, okay, ready, go, and then their arm kind of drops. Like, it's something where I help them to get up there, and I'm like, okay, if I leave it up here, are you going to be able to maintain that? And they say, no, I don't think so, and I try to let go, and then, you can tell, like, if you're not supporting them up there, their arm is going to drop. So it's not really a drop arm test. It's, call it whatever you like, but it's an inability to maintain forward elevation. The external rotation lag sign, I think, Bessem, talked to us about this a month or two ago. It's really important to do that with their elbow tucked in. If their arm is out here, their deltoid is able to do a lot of compensation and fake external rotation. But when you isolate their external rotators by tucking their elbow in, you'll see a lot of people that are able to do this are not able to do this. So getting their elbow tucked in and seeing if they're able to get out here, and if they're not able to get out here, if you put them there, are they able to keep their arm there? And if you bring them here and their arm lags back, that's a pathognomonic infraspinatus tear.
So in
Sorry, go ahead.
in adduction, they cannot use their scapula in their advantage. So what happened when they have weakness in shoulder external rotation, they do slight abduction, they engage the pec latissimus teres major to stabilize the shoulder, and as they're doing external rotation, they start to move the scapula because now the arm is away from the body slightly. Now you can move the scapula back, and you can see as if they have external rotation, which is not correct, which is talking about.
Yeah.
But because you engage much more muscles in this position.
Yeah. So isolating it by keeping their elbow at their side to really see if their infraspinatus is working or not. And then if their infraspinatus is completely out and they have this external rotation lag sign, then you can check them at 90 degrees of abduction. And a lot of times, because if this is the humeral head and here's the infraspinatus, at waist level, the infraspinatus is at the midline, right? If the teres minor is down here, you bring it up to 90 degrees of abduction, and now the teres minor is the one that's across the equator, right? So instead of the infraspinatus, which is dominant at waist level, it's the teres minor that's going to externally rotate them at 90 degrees of abduction. So if that one's out as well, their arm will drop, so that's a positive hornblower sign. And again, it's the same sort of thing, like you don't need to let people's arms completely drop, you can just kind of gently help them, and then if they seem to can't, then you can do that. I don't know what you guys do in the clinic for testing the subscap. I know the lift-off test. I know the modified bear hug. I fairly consistently get a very good prediction on what their MRI is going to look like with the belly press test, and with the PA students that I get rotating with me. We go back and forth over the course of the month and make sure that they can do a good belly press test, because this is not a belly press test, right? This is shoulder extension, right? For a proper belly press test, the elbow needs to be forward, right? So they need to be able to do this. So if a patient's not able to do this, I'll put their arm in this position and I'll hold it for them, right? So I'll get their elbow forward and I'll get their hand on their belly and I'll tell them, keep this position and don't let your hand come off your belly and don't let your elbow come back. And if their subscap is torn, you'll see it very, very clearly. Either their hand comes off their belly when you let go, or their elbow will drop back, but they will not be able to maintain this position without a normal subscap. So I don't know if you guys do a different test that you find to be more predictive, but that to me is the easiest, most straightforward, most predictive test for the MRI.
Well, I tend to do all of them. Like I tend to do the belly press test the way they showed it, or sometimes you pull on their elbows, or sometimes you try to tension to see how much they can rebound. And we do the bear hug, but the bear hug has to be done correctly because many times it is the elbow is down, which is incorrect. And
Yeah, so you gotta.
lift off test is the hardest one, by the way.
Which one?
The lift off test. Lift off test is really hard
Because their shoulders
sometimes.
hurt. Yeah.
Because the shoulder is painful. If they have some stiffness, it will be very inaccurate. So, but I agree with you. But we do all of them just to try to get the feel.
Serena,
I mean,
Vahid?
I'll make two.
Yeah.
Two.
Oh, sorry, but I was just going to say, I think that, I use the belly press too, but, one comment that I'll make is, a lot of times when I'll have a medical student or junior resident go in the room, they'll see a patient and they'll come out and they'll rattle off all the positive provocative tests, positive belly press, positive Neer, positive Hawkins, positive Mayo Shear, positive O'Brien. All of these are positive. And then, what Bassem just touched on, you go in the room and they're stiff, either from arthritis or adhesive capsulitis. And so, the only point additionally that I would make is almost none of these tests are accurate in the setting of stiffness.
Exactly.
Especially a belly press. They can't really into for it to even be a justifiable test.
100%.
That's a very, very good point, by the way, for everyone in this room, because often, exactly what Soraya mentioned, like I have a fellow, the patient has belly press, positive belly press, but they cannot do it because they're stiff.
Right. They can't even get here. So if they can't get behind their back, how are they going to get like this? It's the same.
The belly press is the same because if they're stiff, sometimes they cannot move they cannot just move the shoulder forward. They're very stiff. And I remember very well, we were in either Bulgris or Val d'Isère, and Christian Gerber, because Christian Gerber is great, as everyone know him, but it's not easy to tell him this is not correct,
You didn't do that, did you?
Almost, yes, I did. And but he got a little bit upset, but he said no, there's a way still, because he was saying the patient had stiffness and subscap tear, and she has positive belly press test or lift out. I told him how can you do it? I think if the patient is stiff, it's almost impossible to do it correctly. Oh well, there are ways you can do it around it, but he did not say how. Yeah. It is, honestly, in my opinion, you cannot. And in this stiffness, even though it's not as accurate, but the bear hug test will become easier, because it's in front of the body, and and you put it down, you'll be able to get some feeling about it. For me, it's easier on the patient in stiffness.
Yeah. And I'll echo those sentiments. And one of our PA students is here with us, and she can tell you as much as us how critical it is to focus first on their range of motion exam before their strength exam, right? So if somebody is not able to get here, then the next thing you want to know is what their passive external rotation is, right? Because if their passive external rotation is asymmetric, then their internal rotation is likely not going to be much better than the ilium or the sacrum. And if they have that global loss of range of motion, the limitation in forward elevation, limitation in external rotation, and limitation in internal rotation, then that pathology is not going to be rotator cuff primarily. They could also have a rotator cuff tear, but the primary pathology is that loss of range of motion, because if it's in every direction, it's not a weakness, it's a stiffness. And if it's a stiffness, it's a limitation at the center of rotation of the shoulder. So it's either going to be an adhesive capsulitis or a glenohumeral joint arthritis, which, very easily get an x-ray. X-ray looks normal. Okay, adhesive capsulitis. How do you guys treat that, by the way? What's your go-to? I know this is a rotator cuff session, but just as a aside.
And Mina, can I make a point here?
Of course.
Quickly.
No.
So I think Gerber's study is helpful in a sense that increased passive external rotation is something that you see in these, significant subscap. It won't, differentiate an upper border subscap, but I think in some of these patients, especially if you have a total shoulder that comes and you're worried about their subscap here, that's one of the things I always check. Patient lays down, arm tucked at the side, and abnormally increased passive external rotation in some of these acute subscap tears, or in the setting of arthroplasty, has been very helpful for me. I don't know, you guys find that helpful?
I haven't, but maybe I should be looking for that, just like with the pec minor thing.
Yes.
Maybe. We're learning. So I'll just say for the patients with a normal X-ray and more than 1 month of symptoms of constant pain, difficulty sleeping at night, and loss of forward elevation, passive external rotation and internal rotation, I tend to give them an ultrasound-guided glenohumeral joint injection in the office, and then send them to therapy to work on that last bit of passive range of motion loss with a stretching program that they learned from our colleagues here in the room. Is that something that you guys, because I don't think I necessarily learned that in training. I heard people taking people to the operating room for manipulation, which I'm not a fan of, or a Brisement procedure, which, I'm not really sure if that has the same sort of logical sense to me as treating the underlying pathology for the adhesive capsulitis, which is the inflammation. So I'd rather put less volume but actually treat the problem with the cortisone. So I don't know if that's something that you guys have happened upon, or if it's something that probably Bassem doesn't see very much.
No, I see the severe one. So.
Yeah.
No, but it depends on the stage, though, because
Yeah,
I really, really like the...
Early on, like a month in,
I think it
freezing
is,
phase.
I really, really like the steroid injection intraarticular early on.
Good.
And I really think therapy will work very well for this patient. The problem, the one we see, very rarely ever they come early on. They come after 6 months to a year. And my experience has been, even without therapy, if they came and they have severe loss of motion, this one, they don't get much better without surgical intervention. And I don't like manipulation under anesthesia only without release. I think it's a mistake, other than risk of fracture, but also you can tear rotator cuff, you can inflame tissues. And sometimes you can release one part and part not, because it become even worse. So we do a circumferential release, and we do axillary nerve neurolysis at the same time, because I believe the axillary nerve could be also a reason of pain. It's like the ulnar nerve at the elbow. When we have stiffness, sometimes you release locally on the nerve, and it feels they get better. So when we do for severe cases, which is the only one we do 360 release, and we release the axillary nerve, and 2 days of full nerve block to have motion 5 times per day, and they continue.
Vahid, Serena?
I like that Bassem lives in a utopia where frozen shoulder patients only come to him at 6 months or a year after they've had symptoms. I can't say I have the same patient population. I see them more like you, Mina. I see them at a month with severe pain and starting to develop some stiffness. And I do the same thing that you talked about doing. I give them an injection in the joint, and I have them start therapy. And I tell them all that 90% of them will get better without an operation, as long as they continue to stretch over the course of 6 months to a year. But with the 10% that do end up in the operating room for me 6 to 9 months later, I do what Bassem talked about, which is scope them. I have made the mistake previously of doing a manipulation prior to scoping, because I thought that they were too tight to get the scope in safely. I thought I would ding the cartilage, so I've manipulated them beforehand. And a few times I've gone in and seen some of the damage that I've created, and I've caused a bony Bankart. I've torn a leading edge rotator cuff. So, he's absolutely right.
I think that's really important that you told us that, because I think something that surgeons are criticized for, and people that are sort of experts in something, is that, you just do it your way, and, you don't think about any other way. And I think, all of you guys, I admire that about you guys. It's always like a questioning of like, am I doing the right thing? Am I doing the wrong thing? And I think that story of, okay, like, we've always been taught that the right thing to do is an arthroscopic capsular release first and then the manipulation. But I think it's really important to us to say, hey, it's actually true. Like, if you do the manipulation first and then you get to take a look at what you did. I think that's a really important point, and I think we need to do that more often. Like, I think part of being an expert is not just saying, oh, this is what I know, and everything that I do it right perfectly every time. It's not, I did this, and Man, that didn't seem like the right idea. I'm not doing that again.
So, man,
So-
in overseas, like as you know, I do a lot of work overseas, and for surgeons who don't, I will not say comfortable doing, because if they're not comfortable doing a release, they should not aggressively do manipulation, because so overseas, if they don't know how to do arthroscopic release, they do manipulation regardless, and I've seen bad complication. Honestly, I've seen someone, because when they're very severely stiff, the capsule, the inside is super, super stiff. When you start to manipulate and it will give way somewhere, it may place tension on the rotator cuff. So I had like, among a lot of examples, 17 years old, she had an injury, stiff. They manipulated her, they broke the humerus. Now they have to immobilize her, no fracture. Now she's severely
Now even more stiff, yeah.
osteopenic. And anyway, but just this is what with me, like Sorena was talking about. I don't think manipulation under anesthesia should be done without release.
I agree. Vahid, any final thoughts? Because this is my last slide.
Yeah, I would echo, what Bassam and Serena said. I think some of these studies are a little bit confusing because, as you said, earliest stages of frozen shoulder are always can be treated with injections and physical therapy. And there's a small portion of patients that eventually need, really get recalcitrant frozen shoulder. And I mean, things like Breezemont and kind of, these procedures, I think conceptually for that patient population that we, take to the operating room will be completely ineffective. It's going to burst their soft part of the capsule and is not going to actually be effective. And I'm 100% agree, on the same page that, we should do a surgical 360 release with protection of the nerve and safely. And that's, saves, the rotator cuff. And I personally don't do imaging workup when I see a frozen shoulder patient because it can confuses the picture, because I'm not going to go in and repair a rotator cuff in the midst of a severely stiff shoulder. So I always go through that protocol of 1 or 2 injections for physical therapy, make sure a patient got to 6 to 8 sessions of physical therapy. And as long as they're improving, I tell them if 2-3 months from now your pain continues, then we'll get an MRI. And it's always in the back of your mind that secondary frozen shoulder versus something that's just idiopathic, and you can solve it with the stretching and cortisone. And I think the important factor is these are difficult surgeries. Like, we've done always, it's hard to get the scope into the shoulder. When you are done, even if you're doing very careful, your cartilage gets a beating and all of that. So, I mean, being systematic and doing the releases in a least invasive manner, I think is very important. Staying with your releases as close to the glenoid rim, I think it's important. You can get into the tendon and weaken the tendon, and then you go and do your range of motion. Next, you find, the patient has a cuff tear. So those are hard cases to actually technically do right.
Yeah. Good. I just want to point out to the rest of the room how attention deficit surgeons are, that I said we're going to focus on small rotator cuff tears. And they're like, let's talk about frozen shoulder. What do you guys do? So I in the middle of the conversation, I was like, wait, how do we get on this? It's like, oh, yeah, that's right, because I was talking about the belly press test, and we said you can't do the belly press test if they don't have full passive internal rotation, and then the roof
but
came
come
off.
on, like the therapists, how often they see stiff shoulder and frozen shoulder look.
Yeah.
So they're
all the
okay
time.
with it. That's okay. It's
Yeah,
not
yeah.
the
Oh
excitement.
yeah, no. Like I said, I think it's a healthy ADD. It's not a dysfunctional ADD. It's kind of like a yeah. But I'll just recap real quick. I think the big picture, like Bassem talked about, like where the shoulder blade is in space, like we talked about this morning, is really important. I think understanding the normal anatomy where the tendon insertions are is not as straightforward as we think it is. And I think understanding that anatomy, and we'll look at that very closely in the lab, so pay attention to that. And the functions of these muscles normally is informed by what happens when these tendons are torn. So we'll look at that. We'll compare different types of tears, different patterns of tears, and we'll see how that affects the functional anatomy of the rotator cuff loading. So I don't know if Serena and Vahid are going to hopefully stay with us and heckle me while we're doing the cadaver dissections, but we'll make our way over to the lab in about 10 minutes. Thank you guys so much.
Thanks, Mina. Thanks, Bob. Great talking to you guys. And I think you guys got a great crew over there. Wish we could be there in person.
Next time.
Thank you, Mina. Thank
Next
you,
time.
Bas.
Thank you guys.
Serena, it was good seeing you, man.
You too, buddy.